So let me introduce myself. My name is Ali Ouazzani. I'm specialist orthodontist in Casablanca, Morocco, and I have been for more than 20 years in a private practice. I practice exclusively lingual and labial orthodontics focused on the Alexander discipline. I'm also an international speaker, and I run courses to help spreading the Alexander discipline in Morocco and in some abroad countries. And even I organize courses for the Alexander discipline. I would like to say that I have no interest in any product or material related to the Alexander discipline. I come from Morocco, which lies in the northwest of Africa, a few kilometers from Europe. And before I start talking about the Alexander discipline, I would like to pay very little tribute to my big friend who comes from Iraq, who is Dr. Mohammed Al-Muzian, who is doing a fantastic job during this hard time of pandemic to help people learning orthodontics all around the world by organizing some fantastic webinars with the best top speakers in the world. So we met 6 months ago and we became very close friends, and really I'm very grateful for all what he's doing for orthodontics. Thank you, Mo, from the deep of my heart. I live in Casablanca, which is the biggest city in Morocco. It's blending between modernity and tradition, and also it's the title of the favorite movie of Dr. Alexander, which is Casablanca. Here is my new office when I moved 18 months ago, and as I told you, it's dedicated exclusively to orthodontics. I met Dr. Vic Alexander in 2002 when he was invited by Ormco company to give his first course in Morocco. And I was charged by Ormco to translate the course from English to French. And before he left, he gave me very important present with special dedication. And I couldn't imagine at that time that many years ago, I could be standing on a stage, giving lectures, giving courses about the Alexander discipline. It's like a dream coming true. And being in front of you today, it's like a miracle for me. It's really went above all my expectation and beyond all my expectation. As you can imagine, it's very difficult for me to give all the details in 1.5 hours about the Alexander discipline when it takes me normally 3-day courses to say the same things. So I tried to focus on the main point that make this discipline so unique. I will start with history, simplicity, and stability. Then I will talk about diagnosis, the bracket system. Then I will explain how we deal with orthopedics. After that, I will talk about non-extraction treatment, then extraction treatment. And finally, come down to retention and how we can create compliant patient. And as you can see, it's exactly how we deal with the treatment plan. We start from diagnostic and we finish with retention. History, simplicity, and stability. Let me introduce you Dr. Vic Alexander. He was graduated in orthodontics from Houston University in 1964. And the same year, he opened his private office in Arlington, Texas, few kilometers from Dallas. And he started also teaching orthodontics in the famous Baylor College in Dallas. And in the end of the 60s, he began his quest for looking for a better way to do orthodontics, because he was trained on a treat technique, which is very fundamentals, but also complex technique that did not meet his goal to produce high quality result using simplified mechanics. He understood very quickly that by keeping everything as simple as possible, people can do the right things. But who are these people? First of all, the patient. Less he has to do, and more he can be compliant. If you give a patient very simple things to do, he can help you to achieve a good outcome in the treatment. Secondly, the doctor. If everything is simplified, you can expect exactly what is going to happen the next appointment, and it becomes much more easy. The staff, if they know that there are very specific steps in the treatment, they can well organize the office. It's about the management of the office. And finally, the parents, they can be the real stakeholders of the treatment. They can really help us achieving good results if we explain very easily and very simply what they have to do and what the patient has to do. And when all these people work together and do the right thing, we can achieve efficiency. This simplicity is found in every step of the treatment, and also in the way Dr. Alexander teaches his philosophy and divided in 20 principles. And it's very clearly explained in his first volume and very known book, The 20 Principles of the Alexander Discipline. What about stability? Many people, many orthodontists don't believe in stability, but Dr. Alexander really think that it's reality, and he can prove it, and he proved it many, many times during his lifetime. And all these proofs are found in what he calls the room of truth. It's a room in his office in Arlington, Texas, where are stored more than 20,000 records of patients before treatment, after treatment, after the end of retention, and many, many years after the end of retention. More than 50 master theses were written from this room. These theses come from the most prestigious universities in the United States, Baylor College, New York University, Buffalo University, but also many international dental schools in Mexico, Japan, Brazil, or Italy. Dr. Alexander also contributed in many book chapters around stability, and also wrote more than 100 articles on the same topic. And he defined some guidelines for stability that are perfectly described in his second book, The Alexander Discipline Long-Term Stability. What are these guidelines? It's all about control. The first one is the anterior torque control. We need to control the lower incisor, EMPA, the nasolabial angle, which means the upper incisors, and from the two measurement, the interincisal angle. The second guideline is the skeletal control. We need to deal with the vertical and the sagittal. The third one is the transverse control. And it's explained by the control of the mandibular cuspid to cuspid width, which should not move, the maxillary 6 to 6 width, and the arch form, and we are going to talk about all it a little bit later. Fourth one, the occlusion, and especially the root position, the leveling of the mandibular arch, and IPR. Fifth, we need to finish with a good soft tissue profile and smile. And finally, we need to have safe periodontal health and TMG. And this patient is the proof and the evidence that we can achieve stability. She came in his office in 1980. Some of our followers and participants tonight perhaps were not even born. She was 12 years old. She was skeletal class 2, deep bite with some crowding. Here are her models. She was INB4, so class 2, low angle. And here is the result 2 years after. You can see that the case is perfectly finished. And the purpose of showing this case is not to discuss the treatment plan, but to see what is the follow-up. And here is the same patient, 28 years old post-treatment. She is now 46. And you can see that it's perfectly stable without any retention. It means that the retention was removed at the end of the growth, and after that, no retention, and it remains perfectly stable. It means that if you respect the guidelines, we can achieve stability and long-term stability. What about diagnosis? In order to help doing very accurate diagnosis, Dr. Alexander presented a new simplified cephalometric analysis by putting together some of the most popular lines used to diagnose a case. These lines draw four-sided figure. That's why we call it tetragon, along with INB and the harmony line. And we call it tetragon plus analysis. These findings, along with the study model cast and photographs, are reported into extraction versus non-extraction chart that will guide us to treatment with extraction or without extraction. And in this chart, 8 major factors are studied. Here is the chart. On the left column, we have the 8 point, and for every point and for every, depending on the clinical situation, we can check extraction, borderline, or non-extraction. For example, if you have bioprogressive patient, we know that we need to extract to upright the incisors and to improve the profile. So we are going to check the box of extraction. And we do the same for every point. And at the end of the road, we have a total. If the total say extraction, it will be an extraction case. If it says non-extraction, it will probably be non-extraction case. If it's borderline, we can talk to the patient, to the parent, and start probably without extraction and then reassess. What are these main factors? First of all, the soft tissue profile. It's the first thing we see when patient is on the chair. It doesn't mean that's the only thing we can see. We have a lot of factors to study. It's one among 8 other factors, but it's not the only factor that help us to decide. Second point is the position of the lower incisors, the periodontal tissue, the growth potential, the skeletal pattern. It's very, very important. We don't deal with the high angle or low angle the same way. The arch length discrepancy, the intermolar width, and finally the patient compliance. It's very important to know if this patient is going to help us or not. And we are not going to decide the same treatment plan if we have compliant or non-compliant patients. So the decision is not based on one factor. It's based on the combination of these 8 factors. It's the total that will guide us through extraction or non-extraction. What about bracket system? Even the Alexander discipline is more than a bracket. The bracket system is very important part of the discipline because it's designed to serve the treatment goals. And let's talk about the design and then the prescription. In the design, we are going to distinguish 3 points: precision O18 slot, then single bracket, and finally rotational wings. Why O18 slot? When you use O18 slot, we can have better torque control because we can finish with almost full-size arch wires, at least 1725, that will express all the information in the slot of the bracket. There is no meaning to work on O22 and finish on 1925. We will have loss of torque because there will be a lot of slop and a lot of play. If you work on O22, you have to finish on 21, 25. Otherwise, your prescription will not be expressed. With O18, it's much more easier because we can very quickly and very easily finish with 1725 or even 1825 if we want full expression of the torque. The second advantage is that with O18, we have reduced Archwire sequence. We can start with O16 and finish with 1725, and most of the cases are finished with 3 to 5 Archwires. And finally, the finishing Archwires are smaller, which deliver much less forces, and it's much more comfortable for the patient. So we have better torque control, less Archwire, and more comfort for the patient. Second point of design is that we use single brackets, except for the upper incisors. In all other teeth, we use single brackets. The single bracket will offer a bigger interbracket distance. This increased interbracket distance offers more flexibility that will allow early engagement of stiffer wire, especially rectangular wire from the beginning. Of course, flexible rectangular wire. This possibility will allow us to have efficient leveling mechanics and faster torque control, because when you introduce very early in the treatment rectangular wire, you can very quickly start controlling your torque. See the difference between single bracket and twin bracket regarding the interbracket distance. With the single bracket, we have 50% more space. And this 50% space will decrease by 8 times the rate load deflection for the same wire. So by using O18 with single bracket, not only we have a better control, we have an earlier control, but we have much more force and consequently more comfort for the patient. And finally, the rotational wings. These wings on the single bracket will allow very quick correction of the rotation, but also the control of the correction of the rotation. These wings, like in this drawing, can be activated or deactivated to increase the correction of the rotation. And they are much more superior when there is crowding, because you bond where you can, and it's the contact between the wire and the wing that will create an active force on the wing that will help correcting the rotation. And the good news is that you can bond your bracket off center, and more you are off center, more you have better correction, because you will create a better rotational lever, because you will going to increase the distance between the center of resistance and the point of application of the force. So not only you can bond all your brackets, but you will have better correction of the rotation. And the other good news is that you don't need to rebond the bracket. You can keep it the same place, as the wing will maintain the position of the tooth. And this advantage is something very, very important and very specific to the Alexander discipline, and you cannot find it in any other technique. It's very useful. What about prescription? Let's see the offset, then the angulation, and finally the torque. The most important point on the offset is the upper molar distal offset, which is about 30 degrees in the upper molar and 10 degrees in the second molar. This offset will create mesial out rotation around the palatal root. This rotation, this molar rotation, will offer better molar anchorage, as the labial roots will go in to be anchored on the cortical plate. And it will also reduce the buccal dark corridor, because when the patient will smile, we will see more white, more enamel. The dark or black corridor are not a matter of expansion. They are due to how you are going to position your upper molar. And more they are rotated, more we can see the labiovestibular, the labiomesial cuspid on the smile, and this will help reducing the dark corridor. What about the angulation? There are two specifications on the Alexander discipline. It's to spread the roots of the mandibular anterior teeth for stability reason, and upright the mandibular first molar for easy leveling. Here are the prescription of angulation of tips that are incorporated on the lower braces. We have +2 on the lower centrals, +6 on the lower laterals, and -6 on the first molar. And the reason we have +2 and +6 is to help spreading the roots of the lower incisors. We all know that we have to spread the roots of the upper incisors, but few know that we need to spread the roots of the lower incisors. And here is a study held by William Rayleigh, published in the GCO in 1985, about how we need to spread the lower incisors. And William Rayleigh says that when the root apices are sufficiently spread and if other treatment keys are attained, stability of lower incisors can be expected even without retention. It's something very special to the Alexander discipline. There is no other philosophy that can spread the roots and based on clinical studies. What about the uprighting of the molar? There are two studies held in Buffalo University about how to level the curve of SPE, a cast analysis and long-term cephalometric analysis. And they showed that when we upright the first molar, they can stay uprighted long-term, and this will help maintaining the leveling of the curve of SPE and the correction also of the overbite. Of course, there is an exception. When the patient is high angle, we are not going to use -6 angulation on the molar. Instead, we are going to use 0 degree to avoid uprighting the molars and then creating an extrusion that will increase the vertical dimension. What about the torque? In the Alexander discipline, we have -5 degree torque on the mandibular incisors, and it's the real trademark of the Alexander discipline. This -5 torque will help controlling the flaring of the lower incisors during leveling and alignment. And here is an unpublished master thesis held in Baylor College in 1980 about the combination of the negative torque, the angulation, and rectangular archwire in controlling the lower incisors. I'm going to explain it a little bit later in my lecture. Okay, let's talk about orthopedics. How we deal with orthopedic treatment in Alexander discipline. The most important in the sagittal treatment is to understand that the maxilla and the mandible don't act the same. The maxilla is malleable. We can inhibit its growth, and we can also stimulate its growth. And like the mandible that you watch grow or not grow, if you have a good grower, your mandible will grow. If you have bad grower, it will not grow. So you can act and have an impact on the maxilla, but very few on the mandible. And that makes very big difference. That's why when we have to treat a class 2 skeletal pattern, we use headgear. Whatever the reason, it can be retrognatic mandible, it can be prognatic maxilla or both, we use headgear. How do the headgear work? The headgear is going to inhibit the growth of the maxilla to allow the mandible to catch the maxilla. If your patient, again, it's always the same story. If your patient is a good grower, the mandible will grow and we will obtain very good results. If he is a bad grower, you will have no result. And the difference between the headgear and functional appliance is that with the headgear, we don't have side effects, unlike functional appliance. Because how do functional appliance work? They work exactly with the headgear effect. When you push your mandible forward with the functional appliance and you maintain it in this position, you are just going to wait until the condyle grow backward and upward. But the difference is that by pushing the mandible forward, you are going to have class 2 elastic effects. We are going to have dentoalveolar compensation, flaring of the lower incisors and uprighting of the upper incisors. And also the lower molar will grow mesially and upwards, and it will help correcting the class 2, but with less skeletal effect and much more dentoalveolar compensation. And we all know that flaring the lower incisors, it's not a good stuff. It's one of the most important reasons for relapse. So that's why we treat with headgear and not with functional appliance. It's very, very important to know that it acts and it works exactly the same, but without no side effects for the headgear. And here are 3 studies done in the Baylor College and published in American Journal and in seminars in orthodontics about the use of headgear. And the conclusion is that when used in conjunction with growth, of course, we must have growth, and cooperation, Facebook therapy is highly effective, efficient, and stable way to correct class 2 skeletal problems. So the headgear is very efficient way to solve the headgear, whatever the reason. It can be orthodontic or prognatic. It's the same. It acts absolutely the same. The most important is to have a good grower. If you have a good grower, you will have a result with the headgear, but without side effects of proclination of the lower incisors. For class 3, we use face mask, nothing special. And here is studies published in seminars in orthodontics about how we treat class 2 malocclusion in the Alexander discipline. What about transverse? We do expansion by rapid palatal expansion, which is very predictable. Who are the patients that are indicated for this RPE? Every time you have narrow maxilla, arch, even if there is no crossbite, because we can have patients with narrow maxilla and also compensated narrow mandible. So we can do expansion even we don't have crossbite. And how we can measure it? We need to calculate the upper molar width, which must be more than 33, 34. If it's less than 33, we have to do rapid palatal expansion. Here is the design of the hierarchs we use. And very often, after the rapid palatal expansion, we use lip bumper. Even if it's not an orthopedic appliance, it can help expanding the posterior lower arch to follow the upper expansion. Here is a study, very known study published in the AGO in 1991 about the use of lip bumper that shows that we can have very important transverse change that will offer us a lot of space to treat non-extraction, mild to moderate crowded arches. And a very important factor in this formula by combining RPE and lip bumper is that at the end of this phase, we need to position every individual teeth in their proper axial inclination. And for that, we need to put braces after the combination of RPE and lip bumper. And here is a study that was held by Besheng and published in Seminary in Orthodontics, saying that using lip bumper in combination with RPE and full orthodontic treatment to establish better axial inclination, relatively small amount of relapse were observed after retention was removed. So it's very efficient and very stable way to deal with some treatment when there is a very constricted maxillary arch. So when there is transverse discrepancy, the use of RPE with a lip bumper, if necessary, is very, very efficient and stable mechanics. What about the orthopedics of the vertical? As you know, it's very difficult to control. In the maxilla, we can use TPA, we can use hypal headgear, some screening exercise, but nowadays we can also use stats. And you know that we can improve the vertical dimension by intruding the molars. We need also to intrude the lower molars. The problem is it's very, very difficult to maintain. And there has been a study published in the AGO this year showed that the most difficult is in this formula, when you intrude the upper and lower molar, is to avoid relapse. And there is no way today that will guarantee the stability of the intrusion of the molar, unfortunately. In the first year, we lose almost 30% of the intrusion. So if we use this technique, for example, to close an open bite, there is a big chance and risk to have a relapse. And here is this patient, which represents exactly what we love to treat in the Alexander discipline. It's a patient which is class 2 skeletal, deep bite. And when we see her chin, you understand that she's probably a big grower, but there is a lock of the occlusion, as you are going to notice. There is a transverse lock, and also there is a vertical and sagittal lock in this patient. Look how the maxilla is narrow. Even the mandible is quite normal, but actually it's compensated the narrow maxilla. Here is her OPG. And if we see the tetragon, she is class 2, deep bite, B retrusive incisors. What is the treatment plan? Non-extraction, rapid palatal expander, and cervical fistbone. And look at the results almost 2 years after the beginning of the treatment. Look at the improvement of the profile, the nice smile. No more overbite, everything is almost perfect. Look at the shape of the upper jaw and also the lower jaw. And look how we spread the roots of the lower incisors. This is very important for stability. And also how the lower molar are uprighted, which helped in opening the bite and leveling the lower curve of speed. comparison before and after, and you can see that the A and B came from 5 to 2 due to the headgear, and mainly to the growth of the mandible. With the headgear, we inhibited the growth of the maxilla. The SNA stayed almost the same or reduced by 1 or 2 degrees, but the mandible growth. And when it grew, it helped in the correction of the skeletal cluster. 3 years post-treatment, it's perfectly stable, everything is nice, and it was so nice that this young lady made the cover of the AGO twice in May 2008 and August 2009. And this is, I think, is recognition of the quality of the treatment of Dr. Alexander. Okay. Let's talk now about non-extraction treatment. And before I detail non-extraction treatment, I want to say something very important. The decision to extract depends on the diagnosis and end of treatment goals. It has nothing to do with the appliance. There is no magic appliance. There is no magic appliance that creates bone. There is no magic appliance that will allow you to do less extraction. It's completely wrong and it's a lie. And all the studies have showed that the tooth or the teeth, sorry, don't know the name of the appliance. They act absolutely the same, whatever the appliance you use. What makes the difference and what can help you to make the decision is your diagnosis and your objective of end of the treatment. And the rule is very simple. We should extract every time it's necessary and avoid extraction every time it's possible. No one wants to extract for nothing, but extraction are very important in orthodontics and they really help us achieving very nice outcomes. So every time it's necessary to extract, we do extraction. And every time we can do it without extraction, we do it without extraction. And when extractions are well indicated, they don't ruin the profile. They don't reduce the airway. It's completely wrong. And all the studies have shown that. And everything is available on the literature and on the books and the articles. Everything is known. We should do objectives-driven orthodontics, not marketing-driven orthodontics. Every time I must treat non-extraction, I ask myself one question. Can I treat this case non-extraction in conservative way without violating the rules of stability? This is the most important question. And one of the most important rules of stability is to control the lower incisors during alignment and during leveling. So the question is there a limit to advancing lower incisors? How can I treat this case with a full control of the incisors? How much am I allowed to advance these incisors? And for that, there have been studies held by Nivent and Bunching on the use of lip bumper for gaining arch length. And as you know, when you use a lip bumper, you remove the pressure of the lip and the incisors are only under the pressure of the tongue. So they are pushed a little bit in forward. And they found that with the lip bumper, the lower incisors flared by 3 degrees and they stopped. Exactly if there was a natural limit to the flaring of the lower incisors. And they compared this study with another one made in Germany by Dr. Hansen about the use of herbs appliance and their impact on the lower incisors. And Dr. Hansen found that when he used herbs, the lower incisors flare by 11 degrees, something like 11 degrees. But when he removes hair retention, there is relapse and the incisors upright and they stopped from uprighting at 3 degrees from their original position. Exactly if there were like range of freedom of 3 degrees. So they concluded to the 3-degree rule, which means that you can advance the lower incisors by 3 degrees, it will remain stable. More than 3 degrees, it will be unstable. And the evidence is one of the study held by Dr. Moody Alexander, who is the son of Dr. Vic Alexander, when he compared 2 groups, stable groups, it's a long-term study, stable group and unstable group. And in all the stable group, he found that the lower incisors did not move more than 2.8 millimeter. In the unstable group, it moved around 4.7 millimeters. So when you treat an extraction, you should not flare your lower incisors more than 3 degrees. It's nothing, it's peanuts. So the question is, how can we control this lower incisors? Which mechanic we need to apply to control this lower incisors? Of course, as for every rule, there is an exception. And the exception is when we deal with very low angle cases with a flat or concave profile and retrusive lower incisors. In these cases, we must flare more than 3 degrees to open the bite, to enhance the profile, to level the curve of speed. But the retention will be different. We need to stay in retention much more longer because the lips and the muscles, the outside muscles, surrounding muscles will act exactly the same. They will tend to push everything back. So we need to maintain. But we knew it from the beginning, so we can deal with it at the end. As I told you, which mechanics we should apply to control the EMPA and to avoid flaring more than 3 degrees. And for that, we need some factors that must be present. First of all, we need to have O18 slot single. Good news, we have it on the Alexander discipline. We need to have -5 degree torque on mandibular incisors. Another good news, that's exactly what we have on the Alexander discipline. We should have -6 angulation on the mandibular first molar. Once again, perfect. That's exactly what we have. That's why I told you that the appliance is made to serve the treatment goals. And we need to start from day one with an initial flexible rectangular arch wire, the bigger one, ideally 17 by 25 heat-activated night tie. And if necessary, we can do IPR and use early class 3 elastics. How all this work? A single bracket create an advantage not possible with twin brackets by having bigger interbracket distance. You should place the bracket, ligate each tooth with a rectangular flexible wire. The technology helps us nowadays very, very well because we can have rectangular wires that deliver low force and that are very flexible with the heat-activated night tie. The resistance of the incisors to tip labially caused by the -5 degree torque that is expressed by the rectangular arch wire will place distal force on the first molar that will upright due to -6 degree angulation. And this will gain 2 to 3 millimeters of arch length that will allow extrusion of the bicuspid without flaring the incisors. So let me explain again. We put the bracket and we ligate a rectangular flexible arch wire. When the incisors want to flare due to the natural effect of leveling, the -5 degree torque on the lower incisors will be read, will be expressed by the rectangular arch wire and will create resistance. This resistance will be transferred to the molars that will upright due to the -6 angulation, and this will create some space that will allow bicuspid to extrude without flaring the lower incisors. And here is the study that confirms what I've just said. It's a an unpublished master's thesis held in Baylor College by Dr. Trammell about the combination of application of negative torque and angulation to improve the control of the lower incisors. They took some patients at the beginning of the treatment. They made a CEF, lateral radiograph, put braces and put 17 by 25 flexible arch wire. 1 month later, they saw the same patient and they took another X-ray and they compared. And you can see how the lower molar uprighted and how the incisors stayed upright without flaring due to the combination of the negative torque, the use of rectangular arch wire, and the angulation on the molar. But this is possible because we have an interbracket distance which is increased that allows the introduction and the insertion of the rectangular arch wire. And it's also due to the O18 slot, because with O22, you can't make it because the 21-25 is too hard, is too rigid to enter into the bracket. That's why the O18 slot offers a real advantages. Let's see what happens clinically. Here is a patient, 18 years old, typical Texas girl who came. She was class 1 skeletal, class 1 dental, little crossbite between right first molar. And look how much crowding she had. It's moderate crowding. Her OPG, and let's see the tetragon. She was class 1 skeletal, and look how the lower incisors were in perfectly position. She was medium angle. The objective, the goal of the treatment is to finish the case to align without flaring the incisors. So the treatment plan was to treat an extraction and to attack, to take the control over these lower incisors and to do some IPR because the crowding was not mild but moderate, and the mechanics alone was not enough to avoid small flaring. So we need to help with some IPR, and sometimes we need also to add some class 3 elastics depending on the crowding. Here is the beginning, the initial. The day 1, the brackets were bonded, and 1725 heat activated NiTi was inserted and completely ligated. Look how the interbracket distance allowed the introduction of this almost full-size arch wire. 6 weeks later, things are going better, and he proceeded to the IPR after 14 weeks, 19 weeks, and finally after 6 months, he started the 1722 stainless steel to start leveling the arch wire, and after 8 months, the finishing arch wire. But even I show you a nice pictures, it doesn't mean anything for me, because these pictures doesn't show me if the incisors flared or not. And that's why every time you see a lecture from an orthodontist, please don't believe what you see. Don't believe only the picture. You need to see what happened on the X-rays. The X-rays are the most important, and the superimpositions are the most important. We don't judge a case or appreciate a case only on the picture. We are not on Instagram, we are in the real life. So we need to see what happened really on the X-ray. Here is the final outcome after 18 months, very nice smile. The occlusion. And here is the most important. What happened to these lower incisors? Look, they were 92, they are 93. We had 5 to 6 millimeter crowding. We have a curve of speed, and there is no flaring because of the mechanic. We took the control over these lower incisors. Nowadays, this patient can go into any orthodontic office. We will say, okay, it's a very easy case. Let's do Invisalign. By the way, I don't do Invisalign. Dr. Akram said that I'm doing Invisalign. I don't like aligners. I must have perhaps 2 or 3 cases in my office, and I don't like Invisalign. I prefer things we can control. And I'm not, as Vishnu Raj says, I'm not prostitutes. Okay? In my hands, it's nothing actually. So this patient nowadays can go to an office and we would say, okay, very easy case, class 1, let's do aligners, Invisalign or something else. And we would have proclined the lower incisors. And the pictures would have been very nice, but we would have put these teeth on very unstable position and it would have relapsed. That's the difference. Please, you need to control the teeth. It's very important. Okay. What about the control during the leveling phase? How we level the curve of P on the Alexander discipline without flaring the lower incisors? Because if we avoid flaring during alignment and we flare during leveling, we do nothing. It's completely ridiculous. 2 studies known by the Buffalo studies were made in New York University in Buffalo State, made by Karkara in 1998 and Bernstein in 1999 about how we level the curve of P with the Alexander discipline, long-term study cast analysis, and long-term study cephalometric analysis. They compared 31 patients before and after treatment to know what happened when we level the curve of P with the Alexander appliance and with 17 by 25 stainless steel archwire omega loops tie back with reverse curve of P. You have black the beginning and red the end of the treatment. And we can see that the leveling is done this way. We have extrusion of the first molar by 0.6 millimeter, intrusion of the lower incisors by almost 1 millimeter, and extrusion of the bicuspid between 2 to 4 millimeter. So you can see that we can level the curve of P without flaring the lower incisors because of the angulation of the molar, the negative torque of the lower incisors, and the tie back of the omega loop. We can, with the Alexander discipline, level without flaring lower incisors. And this helps us to treat non-extraction because as long as we can control the lower incisors, we can treat without extraction. But it's not enough. What about stability? What happens after we finish the treatment? So they compared the same patient between the end of the treatment and 11 years post-treatment. And they saw that the molar keep on extruding a little bit, 0.2. The lower incisors intruding by 0.5 and no change. It means that the leveling of the curve of P is very stable and that we can achieve long-term stability. And this leveling allow also or prevent the relapse of the overbite. It's very, very important to know that. So a good leveling of the curve of P not only is very stable, but it allows the complete and absolute correction of the overbite. In order to achieve this kind of result with the finishing archwire that help leveling the curve of P, we need to let it cook. What does it mean? Because of the reduced archwire sequence, we don't need to change the wire every month. We have in the whole treatment between 3 to 5 archwires. We must let them work. And here is an example of 1725 stainless steel reverse curve of P with tie-back omega loops that was introduced after closing spaces in order to level the curve of P, and nothing was done. And look how the curve of P was leveled after 6 months. Nothing was done. We ligated the archwire and we let it cook. And it worked by itself. So please don't rush. Don't try to change the arch wires every month. There is no scientific reason for that. And we see our patient every month. You know why? Because we want them to pay, because most of the patients pay per month. So we let them come back to the office because we want them and we need that they pay, but there is no scientific reason behind that. In some steps of the treatment, you need to keep your arch wire working, especially the leveling arch wire, like the finishing arch wire 17 by 25. So please let it cook. The fourth point, which is crucial, is to establish an ovoid arch form. Why ovoid? What's the evidence behind that? On the left side, you have the chart of two maxillary and mandibular coordinated arch wire. This template was made by a composite of more than 100 of finishing arch wire bent by Dr. Alexander on a stable patient. And this template was studied by Dr. Felton, who made computerized analysis of the shape and stability. He wanted to know if by respecting this arch form, we can have stability. He studied then 90 cases, 7 years out of retention, and he compared them with non-treated ideal normal sample. And what did he find? That the Alexander arch form fit better than any other arch form, the ideal normal sample. It means that this ovoid arch form is very close to the natural arch form we can find in the normal sample non-treated. Second point is that every time we change the arch form from 3 to 3, the case was unstable. And the explanation is very easy, because when you change from 3 to 3 and you use, for example, a broad arch, you expand from 3 to 3. And we all know that expanding from 3 to 3 in the lower arch is unstable. And finally, 50% of commercially available arch wire are similar to Alexander. So the majority of people work with arch forms that are the same or similar to the Alexander discipline. So please don't buy any arch form. Don't buy any arch form. You need to have an ovoid arch form, and don't take your arch wire from the box and put it directly to the mouth. You need to individualize. You need to respect your 3 to 3 distance. So there is a difference between form and the width. You need to use the right form, but also to coordinate your arches on the initial models. It's this way that you can achieve stability. I don't have time enough to explain. I detail it in my course, but what you have to know is that not only you should use the right arch form, which is ovoid, but also you need to adapt on your template and on your beginning model to avoid expanding your cuspid to cuspid on the lower arch. What is the typical Archwire sequence we use on non-extraction treatment? On the maxillary arch, we start very often by 0.16 niti. If there is more crowding, we can start by 0.14 to have initial leveling and correction of rotation. Then we can use 0.16 stainless steel with curve of P as needed if we want to intrude a little bit the incisors, or if we have some space, you can also consolidate with power chain from 6 to 6 to close the space if there are some diastema. Then we can use an intermediate arch wire, which is often 17 by 25 niti to correct the remaining rotation and to start controlling the torque. And finally, we put the finishing archwire, which are 17 by 25 stainless steel with tie-back omega loops. And depending on the case, we can or not add some curve of speed. In the mandible, we need to control the lower incisors because remember, it's non-extraction case. So we have to attack the lower incisors. We start by the bigger flexible archwire possible. It can be 16 by 22 or ideally 17 by 25 heat activated night tie. Then, and we stay in this wire until all the rotation are corrected. If needed, we can do IPR and use some collateral elastics. Then we can use an intermediate arch wire to start leveling the curve of P. It's 17 by 22 stainless steel with reverse curve of P and omega loop tieback. And finally, 17 by 25 stainless steel finishing arch wire with reverse curve of P and tieback omega loop. I know that starting with rectangular flexible arch wire, it's something that can be new for most of the people watching the lecture today, but we do it routinely. It's so logical. There is so evidence behind that, that when you understand the principle, you can use it from tomorrow morning in the office. And it's the only way or one of the best way to control the lower incisors. The problem is most of the people don't know that we are not allowed to procline more than 3 degrees. And there have been a study published in the AGO this year in 2020 about the dehiscence that can occur when we procline the lower incisors. It's a Japanese study, and they showed that when we procline, guess how much? More than 3 degrees, we have much more chance to have dehiscences. And when we procline more than 5 degrees, we always have dehiscences. There is no, there is, how can I say it in English? Nothing is due to is hazardous. It's 3 degrees, it's something that is evidence-based due to the studies of Alexander, but also to this study. So there is really correlation between the two numbers. So as soon as you understand that you should not flare more than 3 degrees, you have to control your lower incisors by your mechanic. What about extraction treatment? Ironically, I wrote this, when does non-extraction orthodontics extract? Because sometimes I hear some people saying, oh, I'm non-extraction orthodontics. Everybody can be non-extraction orthodontics. As soon as you decide to expand, to put your roots outside the bone and to have non-stable treatment and to ruin your profile by creating by protrusion. There is no extraction or non-extraction orthodontist. There is a good and bad orthodontist. That's what makes the difference. We need to extract every time it's necessary. And it's necessary when you have important crowding for stability reason. I hear some people from other technique saying that because I have a good profile, even if I have 11 millimeter of crowding, I would not extract. It's completely wrong, because extracting will not ruin the profile. It will help you maintaining your good profile. Otherwise, we are going to create by protrusion, and by protrusion is not more attractive than a concave profile. So when we extract, not only it's for stability reason, but also to maintain the good profile. The second reason is when we have bemaxillary protrusion to improve the profile. When we have big asymmetries with significant midline shift, we need to extract to camouflage growth, for example, and there are other reasons, but these one are probably the most important reasons. What is the clinical protocol for extraction treatment cases? We start by extraction all premolars, and we initiate the treatment in the maxilla. We align and correct rotation with round flexible wire, and then we start to retract the upper canine on O16 stainless steel tieback omega with curve of P and power chain. On the Alexander discipline, we retract in the upper arch the canine first on O16 wire with omega loops, curve of P, and we change the chain every at least 4 to 5 weeks, if not 6 weeks. It looks exactly like that. We consolidate the incisors to avoid having spaces when we retract the cuspid, and we stretch power chain from molar to cuspid, and we ligate the chain with the bicuspid bracket to avoid impingement of the gingiva by the power chain. And we change this power chain every 5 to 6 weeks to avoid distal movement of the canine and to avoid having a bowing effect. After finishing the retraction of the cuspid, we can start retracting the upper incisors. And we do it with a 1725 stainless steel with teardrop loops and curve of P. It's frictionless mechanic. We don't use sliding, we use mechanic with loops, and we activate when the second molars are not bended or bonded. We activate the 17 by 25 by doing a cinch back behind the first molar, and we open the loop not more than 1 millimeter. So every month we activate by opening 1 millimeter. And when all the spaces are closed, we finish with a 1725 stainless steel with omega loop tieback. What does it mean, tieback omega loop? It means that we are going to place an omega loop at least at 1 millimeter in front of the terminal tube, and we are going to ligate using Steiner plier, not mosquito plier, not Matthew plier, but Steiner plier, to squeeze the omega, because squeezing and tying back this omega with Steiner plier would create active force that will hold the contact points together. If we have some remaining very, very small space, they will be closed. We don't need to do anything after that. It's not the same when you have power chain and you need to change the power chain every month. In this case, you ligate and you forget your wire. And we don't have space that will open because we consolidate the arch with very tight ligature. Tying back is one of the most important and specific points of the Alexander discipline. We need to tie back in order to consolidate space after we close all the extraction spaces. In the mandibular arch, we delay treatment, waiting for driftodontics. Driftodontics is a distal shift of the lower teeth that happen when we remove bicuspid. The exception of driftodontics, or when we should not wait for driftodontics, when we have bimaxillary protrusion in class 1, because we should start in the upper and the lower the same to close at the same time. In some class 3s and in adults, because driftodontics don't happen in adults. And here is the study behind driftodontics, held by Papandreas and Samuel, published in the Anglo Orthodontics in 1983, showing that we can have some physiological drift after extraction of bicuspid on a growing patient. Remember, on a growing patient. So we start working on the upper arch, we extract in the lower, and we follow, we check until the driftodontics happens. And it's much more easy to bond and work on the lower arch after, and you have less space to close. When the cuspids are in class 1, we can start in the lower, and we can use as flexible wire, even round or rectangular, depending on the case. There is no control of the torque at this time because we extracted, so we can use the one we want. The transitional is optional, and we close the space in the lower en masse with 1622 stainless steel teardrop. In the upper, we retract the canine first, and then we retract the 4 incisors. In the lower, we close everything in mass, but not by sliding, with 1622 a teardrop loop. So it's a loop mechanic, but en masse. And then we finish with 1725 stainless steel with reverse curve of P and tie-back omega loops. And here is how we activate the lower retraction arch wire. When the second molar are incorporated, we put an omega loop immediately distal to the molar tube, and for that we need to have convertible tube on the lower molar, and this is something also I want to focus on. In the upper molar and the lower molar, first molar, in the upper and the lower, we need to have convertible tubes so we can place omega next to the 7. And by ligating the omega loop, we can activate the wire. If you don't have the second molar, you can just cinch back your wire. A good advice is that you should heat treat all the stainless steel wires. Don't put stainless steel wire on the mouth if you don't do heat treatment. It will give more resiliency, more elasticity, and the wire will work much more better. Here is a case of a young guy, 12 years old, who came to Dr. Alexander's office. He was class 2 skeletal, big skeletal class 2 with deep bite, lot of crowding and maxillary protrusion, very weird and square upper arch form. Look at his OPG and the tetragon. He was 8 degree INB and by protrusion, actually much more in the upper than in the lower, on a low angle. Treatment plan was to extract the upper first bicuspid and the lower second bicuspid, typical extraction pattern on a class 2 patient, and of course cervical headgear because he was on a class 2 skeletal, so we had to deal with the space and the protrusion with the extraction, and we deal with the skeletal class 2 with the headgear. After aligning and leveling, he started retracting the upper canine on an 016 stainless steel with curve of speed. In the lower, he extracted and waited for the orthodontics. After a few months, look how the canine come backward very easily and in translation, and he started bracting on the lower arch, and he has almost no space to close in the lower because the orthodontics did all the job. After 12 months, he starts closing the space in the upper with the 17 and 25 bull teardrop loop, and in the lower with the 16-22 stainless steel teardrop loops. After 18 months, he put his finishing arch wire, which are 1725 stainless steel with curve of speed. Here is the final outcome. Nice profile, nice smile. Everything is good. And look at the comparison. The A and B, who went from 8 to 3, due not only to the extraction, but also to the headgear, and also to the growth of the patient. And that's exactly what happened. It was a good grower. 3 years post-treatment, very nice stability. Everything is good. Countdown to retention. I am about to finish few slides and it will be done. I think in 10 minutes it will be over. The countdown to retention starts when we close the space and when we put the finishing arch wire and we start coordinating the arches to achieve centric relation occlusion. At this time, we start thinking about retention. After insertion of finishing arch wire, we can use class 2 or class 3 elastics to have the coordination between maximum intercuspidation and centric relation. We can also use midline elastics and some box elastics to start settling the occlusion. We use them for a few months, and when everything is okay, when all the arches are coordinated sagittally, vertically, and in the transverse dimension, we can start settling the occlusion. But before that, there is something specific on the Alexander discipline, is that the class 3 and the class 2 elastics are put on the lateral, not on the canine. We have ball hooks on the lateral bracket, and this will allow to have more horizontal force vector and the less vertical force vector, knowing that it's the vertical vector that is responsible of the side effect, and especially the flaring of the lower incisors. So putting the class 2 elastics on the lateral will reduce the side effects because we'll have more horizontal force vector. When everything is okay, we can start settling the occlusion. And for that, we have very, very specific protocol that happened the last 6 weeks. We use finishing elastics that are 3/4, 2.5 ounce, worn 24 hours. We are going to section one arch distal to the cuspid, and the arch we start with will depend on the vertical pattern. For example, if the patient is low angle, we are going to cut first the lower arch. If he is high angle, we are going to cut first and to section the upper arch. Then he will be asked to put up and down finishing elastics with specific configuration according to the initial malocclusion. I will show you in the next slide. If needed, we can add some vertical anterior elastic. We ask patient to chew sugarless gum. And 3 weeks later, we can section the opposite arch wire and keep on elastics for 3 more weeks. And after, if settling, we can remove the appliance. Here are these elastics, 3/4, 2.5 ounce. And here are the 3 different configurations. If the patient was class 1, we put them like an M and half, and we begin from the lower canine. If he was class 2, the configuration is W with a tail, and we start with the upper lateral. If he was class 3, it will be M with a tail. This configuration always try to overcorrect the initial malocclusion. We always put these elastics the same way we are going to put class 2 or class 3. The vector, the force vector is always class 2 when it's class 2, and class 3 when it was class 3. And so the W with the tail has a vector which is class 2, and the M with tail has result vector which is class 3. And we ask patient to chew gum, sugarless gum, because for 2 years or 2 years and a half, we control the teeth. But in the last 6 weeks, we want to free the teeth and to let them settle according to the physiology of the patient. These elastics are very light, and when he shows, he brings his teeth accordingly to his inner physiology. what you should know is that we don't start this kind of elastic when we have 2 or 3 millimeter open bite. We do it when you already have done some box elastic to reduce the open bite, and when we are very, very, very close. And this protocol is very efficient to achieve perfect occlusion and finishing. When we achieve the settling, we do retention, removing the upper braces, taking an impression to put a wrap-round design in night wear. Dr. Alexander always says that it's completely ridiculous to make a big effort to achieve an occlusion, a good occlusion, and then use Howley with occlusal claps. That will ruin your occlusion. So you should use this wrap-around design, which is not very easy to do. So if you don't have this, you can use Esthetics. Esthetics in a night wear time have no impact on the occlusion. On the lower arch, we use 3-to-3 bonded retainer. And the retention follow-up is that the patient is seen every year for a visit, and we continue retention until the growth is over and the wisdom teeth are solved. What does it mean? If they must be extracted, they are removed, otherwise they are on the arch. As soon as the growth is completed and the wisdom teeth are solved, we should remove the bonded retainer. It's not physiologic to keep, it's not natural to keep a wire all the life of the patient. We are not looking for lifetime retention. We are looking for lifetime result. Of course, there are some exceptions when we should keep the retention, especially peri cases, some adults, but in children, if you respect your guidelines of stability and you do the right thing, you have a big chance to have stability when you remove your arch wire. So we remove the arch wire and we proceed to small, very small IPR. We transform the contact point into contact surface to have like the bricks in the wall that will help maintaining the result. And I can send you to the studies of Peck and Peck about the IPR and how it helps to achieve stability. And the last point before I finish is creating compliance. We are as good as our patient. You can be the best orthodontist in the world. If your patient does not help you, you will achieve nothing. So we must learn how to make them a part of the treatment. The technique of compliance can be taught just as the mechanic of orthodontics, and it's so important that we have an issue of the GCO of September 1996 with how we can create compliant patients. And everybody should know that there is no non-compliance orthodontics. Non-compliance orthodontics is less objective orthodontics. We have to try and to do all we can do to achieve the best result, not to adapt to the patient. We need to bring the patient to our level so he can help us to achieve the good outcomes. And for that, there are some techniques that can be applied. And before I finish, I would like to really pay tribute to this fantastic man who changed my life, changed my patient's life, and the lives of many, many, many wonderful orthodontists all over the world, because he was so inspiring as a professional, as a man. And here are some of his best quotes, like effort equal results, keep it simple, there are no little things, discipline, give back, self-confidence. We are good as our last performance. There are some of his very famous quotes that help us every day to treat the patient the best we can. I would like to thank him very, very much, especially then that in 2017, he received one of perhaps the best awards in orthodontics that made him a legend in orthodontics. I would like to thank him for all his legacy that will continue through some people that help teaching the discipline and spreading the discipline, and people like you who invite me to share my knowledge about the Alexander discipline and my passion for this discipline. And I would like for that to thank you from the deep heart of Morocco for attention. And I hope that it was useful and that you learned some of what makes the discipline so unique and so powerful, so excellent, and so evidence-based.